call. I just want to welcome you to Series 9, Week 4. And today we're going to have a very interesting topic to discuss. We're going to talk about environmental cleaning and reprocessing of medical devices, and then also have a country perspective on the environmental cleaning toolkit that was running out and the impact on COVID. Just for our people to understand, I want to just say to you, please keep your microphones muted and your videos off. There is a question and answer box. If you have any questions, please post it there. The chat box is just to say hi, but don't post your questions in the chat box, please. We will attend to all the questions as we are going along or at the end live. So if you have any questions for the speakers, please just keep it there and we will take it after the end of all the speakers. Just want to also remind you that we will have a 5-minute health break for the interpreters in between, and we will let you know as soon as they're on. So if you can just stay on the line, please don't leave. It's not because we are closing the series, but because we are just giving them a time to just get their voice back and be able to relax a little bit. So I'm first going to introduce Molly Patrick, which is an environmental engineer, and she's currently working with International Program in the Division for Healthcare Quality Promotions at the U.S. Convention in Atlanta, Georgia. She began her career with CDC in 2010 and worked on water, sanitation, and hygiene, and international emergency and for the last 6 years. She also joined ICP in 2017, where she is coordinating the environmental infection prevention and control activities, including healthcare, waste management, and environmental cleaning portfolios. Molly has got quite a wide variety of experience, and Molly has also done a Master's of Civil and Environmental Engineering from the Massachusetts Institute of Technology and a Bachelor of Environmental Engineering and Environmental Sciences from Dalhousie University and Arcadia University in Canada. So just also would like to welcome all our panel from Africa CDC, Prof. Shadai Ogansalo, which is the chair of ICAN, Dr. Dami, it's also here, one of our speakers, Michelle Osborne from South Africa, Ario is also here, and all the interpreters. There will be an interpretation of Portuguese and Arabic as we are going along. So we would just like to ask our speakers to speak at a space for them to be able to keep up with what you are trying to relate to all our attendees. So I'm going to hand over to you, Molly. You can share your screen from here. Thank you.
Great. Thank you so much, Anna. Thank you so much for having me. I'm really happy to be here. I'm just waiting to see, sorry, my screen has frozen. I just want to make sure it's in the presentation mode. Can you see the slides?
We can see your slide. It's not in presentation mode yet.
Okay.
But now we can only see part of it. It's sort of split. There you are. That's better. But now we can see both. We can see the first and the second slide.
Ah, oh, okay.
Just go to your display settings on top or go to slideshow here.
Yeah, let's try this again. And now? Is it still with the split?
It's still with it. We can see both the first and the second slide.
Okay, I'll just try again. So I will just start to say, again, thank you so much for having me. I am going to be presenting for about 15 minutes. This is an abbreviated version of a presentation that I did last year on this series. So I'm really happy to be back. The main focus of my presentation will be focusing on sharing environmental cleaning best practices. These are best practices that apply during the COVID-19 pandemic. They apply beyond the COVID-19 pandemic, and they do apply in all of our healthcare facilities. I have it in presentation mode. Is it still the split screen? If it is, you'll just get a sneak peek of the next one. I'm not sure what else.
Yeah, it's still the split screen, but I think we can go ahead.
Sorry, I'm sorry about that. Yeah, I will try one more time and then I'll just go ahead. So I'll start with just a very brief, and maybe I'll actually share this.
Yes, now we can see it.
Okay, great. Okay, so I'll just use this PDF version. So I will very briefly just set the stage with some key definitions and resources. I will mostly be focusing on summarizing some of our best practices for environmental cleaning. And then I will close with actually introducing, as Anna mentioned, a new toolkit that we are working on. We're currently piloting it with partners in Nigeria, Dr. Dami, who will speak as well. So I'll just provide a brief introduction to that, this toolkit that will actually help facilities implement best practices, which I know is very difficult. So just to start off with definitions here, just to make sure that we're all on the same page. So I will be talking about environmental cleaning in healthcare. We do have a presenter talking about instrument decontamination, but environmental cleaning is really focused on cleaning and disinfection when it is indicated based on risk level of environmental surfaces and the surfaces of non-critical patient care equipment. Environmental surfaces are really all of the fixed items and the furniture in our patient care areas. They include, tables, chairs, the floors, the walls of the room, and really focus on areas that are frequently touched by healthcare workers or patients. So items such as bed rails, light switches, doorknobs. The picture depicted in the top right shows, I believe it's showing us microbes or contamination, and it's really highlighting surfaces and areas in patient care rooms that are frequently touched. So that is the focus of environmental cleaning. Environmental cleaning also includes in its scope cleaning of non-critical patient care equipment. So this is equipment that comes into contact with intact skin only. So it's not medical devices that contact mucous membranes, for example, or enter sterile spaces. It is only for equipment that is used for care, routine care, and only intact skin. Some key examples I've listed here include IV poles, blood pressure monitors, bedpans, for example, incubators, wheelchairs. So this type of equipment is also reprocessed via environmental cleaning. I actually am not going to focus on COVID-19 too much. The talk that I did last year did, and this slide is from that. But some of the key messages are here for environmental cleaning. The main one that I want to emphasize here is number 3, which is that environmental cleaning using our existing best practice methods and strategies is effective against SARS-CoV-2. So this is really important for us to know that we don't really have to do anything special or different. Our existing best practice methods are effective in the current pandemic context. I also wanted to point out the link at the bottom, and this will be included in the slides to share with you all in case you have not seen. But WHO did publish a focused interim guidance document on environmental cleaning in the context of COVID-19, and that is a wonderful resource. So I wanted to highlight that for you all. There are a number of key documents that I also wanted to highlight very briefly that have great content on environmental cleaning in healthcare facilities. Many of you are likely familiar with these already. The first document on the left is actually a very old document published in 2008, but it is really the WASH standards that are still referenced for healthcare, and there's great content in there for environmental cleaning. I think with a particular emphasis on smaller facilities, The document in the middle is a WHO implementation manual for MDROs that was published in 2019 that has a dedicated chapter on environmental cleaning. And finally, the document on the right is our best practices, which was jointly published by CDC and by ICAN in 2019. And that is really the emphasis of the content that I will share briefly today. So this is an outline of the main content chapters in our best practices. You can see chapter 2 is the best practices for environmental cleaning programs. So what we really need to have in place at our facilities to ensure that environmental cleaning is implemented well. The next 2 chapters are more technical chapters on supplies and equipment best practices and procedural and protocol aspects. But I'm really going to focus on these best practices for cleaning programs and just provide a brief overview. So these best practices for cleaning programs are really built on a multimodal approach that we use widely in IPC. There are 5 main program elements shown here. So I will very briefly go through all of these. As I mentioned, these are best practices that are relevant in all types of facilities. And they're relevant no matter whether cleaning is conducted by facility staff or if it is contracted to an external company. So they're very broadly applicable. So I want to start with the first best practice element, which is about organizational structures. So this is really about ensuring that the systems are in place at our facilities to support environmental cleaning. And there are 3 main aspects here. The first is on the really critical administrative support that is needed. So that's administrative and leadership support. And you can see the components that are highlighted under this realm. So importantly, I want to point out that it is best practice to have a designated manager of environmental cleaning or a focal person that is a facility staff and is really the focal point for environmental cleaning activities at a facility level. Depending on the size of the facility, this could be a full-time position in some cases, and it certainly is in the US that we have full-time position managing environmental cleaning programs in our hospitals. It could be a part-time position. We generally recommend that this person would not be the same person as the IPC focal point, for example, because there are a lot of other activities that would be required of that person. Having a policy is really important, a dedicated budget. I think we know this for other areas of IPC. This is really important to support activities. The second point is about the importance of communication and integration of the cleaning program. So this is really ensuring that cleaning programs are integrated into IPC, they are seen as a core IPC activity. In some of the areas there you can see. The third point is on management and supervisory structures. So I think important to highlight here, in addition to having an organizational chart, so it's very clear who are the staff involved in environmental cleaning, what are the reporting lines, whether that's direct reporting lines or perhaps indirect relationships between environmental cleaning staff and IPC, or let's say ward in charges, for example. It is also really important that there are on-site supervisors for environmental cleaning staff to really support their work. A little bit more on the importance of staffing and training. It is very important that there are formal staffing, or that environmental cleaning staff are recognized as formal staffing, formal staff, IPC staff that with job descriptions and performance standards. I know in a lot of settings, environmental cleaning may be performed by porters or even volunteer staff in some settings. And so we really want to try to move things towards actually having these be full-time employees and recognized as healthcare staff. Likewise, environmental cleaning staff should be trained. There should be formal training, and some of the best practices for that training are highlighted here in the box to the right. They really should be trained on IPC, of course. There should be lots of hands-on work during the training, and importantly, safety aspects included in that training. I want to move on. The third point here is on the supporting infrastructure and supplies that we need to support environmental cleaning. So this is really about the built environment. And there are four main components here for best practice. The first is that we should have dedicated space available at healthcare facilities, and that's to allow storage of cleaning supplies and equipment, to allow a space for preparing our cleaning solutions, for reprocessing our cleaning equipment. And we should also have really a dedicated sluice area for reprocessing of non-critical patient care equipment, which oftentimes cannot be performed at the bedside. So we really need to have dedicated space for this. Really important, the next point is about the necessary water and wastewater services, or the WASH services, to support environmental cleaning. And I know this is a big challenge. And the third point is also a challenge, which is really about our supplies and equipment. We need to make sure that we have standardized supplies, that they are well maintained, that we have procurement and supply management systems in place to ensure that we don't have stockouts. Some pictures here on the right show, some of the supplies that we would recommend. Some of the other best practice components, for example, having color-coded cleaning cloths is a best practice. So that is really important, but I know is a challenge. The fourth point is about policies and standardized procedures. So I made reference to needing to have a facility level policy and needing to make sure that that is validated and supported by leadership, and that the necessary budget is in place. But this just outlines some of the components that should be included in the policy that would be that would really guide activities. I've highlighted the second bullet, which is on the cleaning schedules, which I'll just talk about briefly, because this is really important to describe how cleaning should be conducted, the frequency that it should be conducted, and how it should be conducted in different types of patient care areas. It's also very important that we have standard operating procedures for all of our cleaning procedures. So that we would expect to have, by different types of patient care areas. We also recommend best practice to have SOPs for preparing of cleaning products, including disposal of cleaning products and supplies, SOPs for how to reprocess our non-critical equipment, and job aids as well to help environmental cleaning staff. Things like checklists and pictorial, visual aids are very helpful for cleaning staff. I just wanted to make a point on cleaning schedules. So this table is taken from our best practices, and there's really good guidance in there about recommended cleaning schedules based on the type of clean and on the patient care area. So there's very good information in there that could help you develop your own cleaning schedules within your own facilities. But cleaning schedules really lay out clearly the frequency of cleaning, who is responsible for the cleaning, because oftentimes there can be some confusion between cleaning staff and nursing staff, let's say, for example, about who is responsible for certain tasks. And it lays out the products and technique. And again, these cleaning schedules are maybe different in each patient care area based on different risk associated with those areas. So we also have guidance in the best practices about how to perform those risk assessments that will help determine cleaning protocols. The last point on best practice is about our monitoring and feedback and audit systems. I would say here that at a foundational level, monitoring and feedback is most important. So that is internal monitoring that would be conducted routinely. It is best practice that our monitoring activities use an objective method. And there are some options included there in our best practices to help guide that. But we also really recommend that monitoring includes direct performance observation. And the reason is that this is really important. While potentially more time consuming than some of the other methods, it's really important to improve cleaning practice. It really helps with the feedback that we need to provide to staff to improve their practice. It can be used for coaching, and it can also help inform training needs if we can identify, areas where there seems to be less understanding. Program audits are very important as well, but are more of an advanced element, I would say. Once other best practices are in place and cleaning programs are really well established, it's also recommended to do a larger program audit with some frequency. So just a few words to summarize what I've shared very briefly on best practices here. So we know that it's very important to use multiple strategies or a multimodal approach to support cleaning programs at our facilities, and that strong leadership and organizational support really underpins everything, which is true of all of our IPC activities. The second point, so cleaning staff really should be empowered and trained. We ideally need to be having, supervisors available on the floor for them to really improve practice and help with monitoring and coaching. We need to make sure that our cleaning supplies are well managed at facility level and really set up those systems to support procurement so that we don't have stockouts. And then we need to make sure our cleaning schedules and protocols are well defined with level. And finally, that we should try to have routine monitoring of cleaning activities just to make sure that things are done well. So all of this to say, we recognize that there are a lot of best practices, that they are very difficult to implement in practice, and we understand the context that many of you are facing with cleaning being under-resourced and really a challenge to try to make improvements in your facilities. And because of that, we published the best practices in 2019 and pretty much at the same time started working on the products that we could develop to help with implementation. So, how can we actually help facilities implement these best practices? So we have developed an implementation toolkit, which, as I mentioned, is currently being piloted. And the goals of this toolkit are to help provide a standardized process for assessing your cleaning activities, your cleaning programs against the best practices, and identifying the areas that need to be prioritized for making improvements. We have guidance to actually help with that prioritization. So really identifying, what are the foundational elements? What do we need to do first? And then helping making those improvements systematically over time. The toolkit uses the implementation approach that we see in many of our other guidance documents. So it uses this continuous quality improvement model. The 5 steps are included there on the left. So the toolkit is divided into these 5 steps. And the idea would be that facility-based team, within the context of doing, quality improvement could take the toolkit and really use a structured approach to make improvements to cleaning practices. On the right, this depicts 2 major milestones, which are described in the toolkit. So we have divided things up into what we're calling a basic program, which is really the minimum requirements for environmental cleaning, where you should start. And then it progressively works up to an advanced program, which is all of the best practices and would sort of help once the basics are in place. So I think I just included a snapshot of how the toolkit is laid out, but I won't go into that. So I just wanted to close just to tell you about this toolkit, which we're really excited about. And Dr. Dami, who is the 3rd speaker today, will talk about the first experience of actually using the toolkit in Nigeria. So I'm excited for him to share that with you. Our plan is that we would be closing these pilots that we have underway, making improvements, and aiming to publish this toolkit with ICAN, hopefully by the end of the year, but we will certainly share more information, and we'll look forward to having others of you hopefully using this toolkit and making improvements on environmental cleaning. I will stop there. Thanks.
Thank you very much, Molly. This is really great, and I think everybody will want to see this as well. And I think after we've listened to Dr. Dami, they will realize, what it all involves. Our second presenter I want to introduce you is Sister Michelle Osborne. She just recently retired as Infection Prevention and Control Manager for one of the private Mediclinic groups. She was in that post for 19 years, and she also serves on the Western Cape Infection Control Society, and she's been the past chairperson. She's got a vast experience in infection prevention and control, and she's got an absolute passion for IPC. Over to you, Michelle.
Okay, good afternoon, evening, morning to everyone. I'm just going to share my screen. Okay, slideshow. Okay, can everyone see my screen? Everyone okay?
We can see your screen.
Okay. Also, thank you for the invite, and once again, just giving a very brief outline on my topic, decontamination of medical devices. We know that it is quite a vast subject, so we will just focus on the most important areas. Okie dokes. So I'm just going to quickly just start here. All right, so as I said, we're going to be speaking about decontamination of medical devices. Okay, so our objectives is to understand the term decontamination, know all the methods and processes, understand the differences between cleaning, disinfection, and sterilization, understand the prevention of potentially pathogenic microorganisms from causing infections, and then also how we are going to protect our healthcare workers. So the incorrect decontamination of any clinical or non-clinical equipment is vitally important because we can actually drive healthcare-associated infections in our healthcare facilities. Medical equipment and instruments should be thoroughly cleaned before being disinfected or sterilized, and I'm going to explain that a bit in detail. Disinfection using heat is preferred to chemical disinfection, depending on the manufacturer's guidelines. And decontaminated equipment needs to be stored correctly post-cleaning and sterilizing to prevent further or recontamination. Each step of the decontamination cycle is crucial. Shortcuts can lead to patient harm, endanger the lives of patients, and can lead to huge cost and litigation. So in going back to 101 of infection control, we just know that we are looking at our routes of transmission, and that's through contact, through direct or indirect contact is how our equipment can be contaminated. So the question that always hangs in the air is how long do these bugs last on surfaces? And Danza in 2014 put out this research paper. So you can see here there's a number of variants that occur. But if you look at SARS-CoV-2, it can survive up to 3 days on a surface, but this was under experimental circumstances, and it depended on the inoculum, how much of the virus was sitting there. There was a question earlier on the Q&A now. So it's been deemed that it can last on cardboard for up to 24 hours, on stainless steel for 72 hours, and on plastic for 72 hours. But we must please just remember here, if we are not cleaning our surfaces regularly, this is when you're going to find the virus. Otherwise, if you're cleaning regularly and you've increased your routine on wiping down surfaces, the chances of SARS-CoV on any surface is reduced. So looking at decontamination, we know it's a process which removes and destroys contamination and thereby prevents microorganisms and other contaminants from reaching a susceptible site in sufficient numbers to initiate infection or some other harmful response through direct or indirect contact. Decontamination is a process followed to ensure that reusable medical devices are safe to use on the next patient. And please believe me, you might be that next patient. So it includes cleaning, disinfection, and sterilization. So if we look at cleaning, we know that it is the physical removal using a detergent and water of soil or contamination, such as organic material, from surfaces or objects, making them safe to use or touch. 80 to 90% of microbes are then removed. Your disinfection process removes microorganisms from non-living objects except spores, and here we can use chemicals and heat disinfectants. Your sterilizing is the process that makes instruments free from microorganisms, including your spores. So what is a medical device? It is any instrument, apparatus, material, appliance, or article, whether used alone or in combination, including the software necessary for its proper application intended by the manufacturer, used on humans for the purpose of diagnosis, prevention, monitoring, treatment, or alleviation of disease. So all directives come out through the manufacturers because they are obliged to provide full detail on how to decontaminate the reusable device they supply. This should include compatibility with heat pressure, moisture, processing chemicals, and your ultrasonic baths. So what happens now? We know that a risk assessment has to be done for all devices that are used to establish the level of contamination, the level of decontamination required for that instrument, the type of device. Is it non-critical, semi-critical, or critical? And we'll speak more of that now. The purpose of the instrument, and where does it get used, on what type of patients. Know your profile, your multi-drug resistant organism profile of your institution, and then also what organism are you dealing with? A bacteria, a virus, a spore forming, or a prime. So here are some questions that one must ask when deciding on a decontamination method. What is the purpose of the device? Is it invasive? What is it used for? And we're going to speak on Spalding's classification also in a bit. The manufacturer's reprocessing instructions, they need to specify what actually needs to be done with the type of instrument that they've provided. Can the item be reprocessed? Can it be cleaned properly? And are there available resources for cleaning and sterilization of them? Are the resources and the facilities required for cleaning, disinfection, or sterilization available locally? So what is available, you must ask yourself. Never compromise on the lack of decontamination required due to the lack of resources. And then how soon will this device be needed? We know that in some CSSDs, in some theaters, the device is only perhaps 1 or 2, and you've got 5 patients on the list. How do you go about reprocessing effectively and efficiently that that item is then safe for the next patients? So Spalding's classification of medical devices and equipment was developed in 1970 to determine the level of reprocessing required. He divided it into 3 categories. You had your critical or your high risk item, your semi-critical, your medium risk item, or your low risk or non-critical item. And it's based on the risk of infection due to contact with various types of devices. This table spells it out very nicely for us, the classification and risk category, the definition, the recommended level of decontamination, and then your examples. So I'm going to leave this for you to take home with you so that you can look at what you are thinking about cleaning and then deciding whether it's low risk, medium, or high risk, and then what type of decontamination is needed. Low level, intermediate, high level, or sterilization. And there are a few tables coming up. that will further explain this. Your decontamination cycle. So before we even think about cleaning anything, we actually need to look at, when we buy an item, what it is going to be used for, what the manufacturer says, how we can clean it. And that is also looking at your loan instruments. And the bigger hospitals, I know you get a lot of loan instruments coming in and out of your areas. Some of you might not even know what I'm talking about, but like those loan instruments, were they clean? Can you just use them straight off the bat, or must you actually put them through the process? So in any department, your central sterilizing department, you've got a cleaning aspect, you've got a disinfection area, then you're going to inspect your instruments, you're going to pack them because they're going to now be sterilized. Once they've been sterilized, you're going to transport them to a storage area. They then get used again. When they're dirty, they get transported back to the CSSD, and then the cycle starts all over again. So this is important for your CSSD component. So the general principles is that single items should never be reprocessed. All reusable medical devices must be processed in a decon area. No cleaning or packaging of medical devices should take place in a clinical area. Medical devices should be rinsed off to remove gross soiling at point of use. That's a very important point, okay? Try and rinse it off where you have used it. Medical devices should be transported safely to the area of decontamination. And then your decontamination units, your CSSD, must have separate dirty and clean areas for reprocessing, proper ventilation. Your staff must also be either work in the dirty area or the clean area. There must be no crossover of staff or equipment. And then also make sure that the equipment used for decontamination and sterilization is functional, and that the processes are validated and regularly maintained, and that is vitally important. So in terms of SARS-CoV-2, we know that cleaning of the environmental surfaces and devices is important to mitigate the spread of COVID. But we have, and we've learned over time now, that it is susceptible to standard environmental cleaning practices, as mentioned by the previous speaker as well. And then I've just put here as for reference for you, if you want to go look at this particular site, you can find a table on the method of cleaning and the recommendations for patient care articles and medical equipment on the wards and clinical areas. It's a very lengthy table, and I advise you to go and have a look-see at it. Okay, so here we have various methods of decontamination. So we look at cleaning, disinfection, sterilization, gas plasma, incineration, and flaming. We are going to focus mainly on the first three. Which items we've already asked this can be decontaminated, and I want to say only those that give you the stipulation that they can be reprocessed. If this sign is on any of your packaging, it cannot be reprocessed. Can we perhaps mute the person, Anna? Sorry.
So, hello, the interpreter for Arabic. You are having a voiceover. Mute yourself, please. Over to you, Michelle.
Thank you. Okay, so cleaning, if you look at cleaning, we're looking at the manual cleaning at the sink. Okay, so wherever your sink is, mainly in the slush room, you're going to be wearing the correct PPE. So what requirements do you need? You need water, you need mechanical action, so you need wiping, you need cloths, you might need flushing, there might be some devices, some syringes that you might need to use, brushes, spray guns. So those are all items that you need to carry out the mechanical action. Chemical action is the enzymatic detergent that one would use, and in most cases it's called endozyme. Heat, sometimes the water needs to be lukewarm or even hotter because it might improve the detergent performance. But there again, you need to look at your detergent and you need to see how it is best to be mixed. You need time to clean something well, and you need access to all the surfaces. That is very important. So in the cleaning, we want to prepare fresh cleaning solutions, use clean, dry equipment when cleaning instruments, clean all horizontal surfaces, change your solutions frequently, dispose of the cleaning solutions often if they become very soiled, leave the surfaces dry, clean the disinfectant items, dry them and store the equipment so that there's no chance of recontamination. And then remove your gloves and wash your hands. So these are just the basic concepts for cleaning. Here I've put in some pictures how we demarcate the basin so that we know exactly what the water level must be for the amount of detergent needed. So here for 15 mils of endozyme or the enzymatic cleaner, you need to mix it with 5 liters of water. So the staff know that level will be your 5 liter mark, and the higher one would be your 10 liters. So then they'll put 30 mils in. Here's just the cleaning of the instruments using a brush below the water level. Never use a metal or wire brush. So your do's about cleaning of medical devices.
Daddy.
Ensure the detergent is prepared at the correct concentration, temperature, and that the recommended contact time is used. Keep instruments moist and clean as soon as possible after the procedure. Disassemble the instruments prior to cleaning. Open hinged instruments. Use appropriate size brushes. Use soft bristle brushes to clean the serrations and box locks. Inspect the instruments after cleaning because you're preparing them for disinfection and sterilization. Clean the instruments under the surface of the water to reduce the risk of any aerosol production. And obviously follow the manufacturer's guideline. The don'ts about cleaning medical devices: some disinfectants, especially bleach, can be corrosive. They can leave a residue. They can be inactivated by the organic matter, so it can be a waste of money. Can cause toxic reactions to the staff if used incorrectly. Don't use water hotter than 45 degrees as this coagulates the protein or the organic matter, and then it's difficult to clean the instrument. Never use hard or abrasive items, and also don't scrub under a running tap because this can also produce aerosols. Then you look at disinfection. So we've done the cleaning. Now we're going to look at how we're going to disinfect it. It's used for heat-sensitive instruments and equipment, for skin and mucous membranes, and for the environment. So there are definitely 3 areas where disinfectants can be used after the area has been cleaned. Here is the microbial disinfection hierarchy for intrinsic resistance. So here, these bacteria sitting high up on the table are mostly resistant and they need high-level disinfection. Your middle of the road bacteria need mid-level disinfection. And down below here, your gram-negatives and gram-positive bacteria, some HIV and SARS-CoV-2 only need a low-level disinfectant. This is also very important when you are purchasing your different types of disinfectants. You need to know what action and what microorganisms they will be work well against. So please just make sure you read the small print. Your disinfection agents are suitable for heat-sensitive items. Processing is at point of use. It's rapid, it's inexpensive. Your disadvantages is that it's less effective than heat. We heard that earlier. Items cannot be wrapped. Rinsing's needed to remove the toxic residues, and your validation can be problematic. This table gives you some wonderful guidelines for the factors that affect the effectiveness of the disinfection process. So here we're going to look at the quantity of the organism, the organic matter, the resistance profile, the concentration, the physical and chemical factors, the duration of exposure, and the stability. And I would like for you to also take this home with you so that you can actually understand why you need to look at these factors in choosing the correct disinfection process. In SARS-CoV-2, we know that we're not only to look at SARS-CoV-2, but other clinical important pathogens. And in the context of SARS-CoV, the following disinfectants have been effective to achieve a greater than 3 log reduction of the human coronavirus, according to Kampf in 2020. And he's agreed that and stipulates that ethanol more than 70%, that your alcohol, hydrogen peroxide, and hypochlorite solutions, 1,000 parts per million, can be used as a disinfectant for SARS-CoV-2. Other disinfectants can be used, but they must have then demonstrated action against any other viruses and other organisms. Here's also another table that just lists some disinfectants for you, looking at the active ingredient, looking at the spectrum of activity, and then the level of disinfection. So you can put those tables next to one another, and then you can decide on the correct disinfectant for the correct item that you are wanting to clean. We look at glutaraldehydes are well used over the world. We do know that the contact time can be between 10 and 30 minutes, depending on the concentration. And we do know that the glutaraldehydes have a pungent odor and can be, the fumes can be quite toxic to the staff member. So they do then use the OPA or the Sidex OPA solutions and not the heavy concentrations. Your alcohols are used mostly in the lower resource countries. It has a holding time of 60 seconds. Its action is very rapid. It's bactericidal, fungicidal, virucidal, and it evaporates, leaving the surfaces dry, and it's non-corrosive. But however, it's not sporicidal. That is why we can't use alcohol to kill Clostridium difficile. That is a spore. So that's why alcohol cannot be used. We have to wash it away. It can be flammable, and then it does not penetrate organic materials. The item has to have been cleaned properly, and then prolonged immersion may damage the lens. Your chlorine releasing agents, and these are also used in your lower resource countries as well as our high resource countries. And these are some names that you might have heard of before: Biocide, Medisure, Synthol. And these are active against most organisms. They release an active chlorine measured in parts per million. So you can have a spectrum of 250 to 10,000 parts per million of free chlorine, which is usually required for any disinfection. Its holding time, general disinfection, is 30 seconds, but for viruses, you can allow contact time of 5 to 10 minutes. Here's just some concentrations per million that you would use, and you can look at this at your own leisure. Okay, so blood spill, you want 1 to 10,000 parts per million. Drinking water, you want very little parts per million. Here's a lovely table showing you the method for diluting hypochlorite solutions for different concentrations, and it's all dependent on the available chlorine. So you need to know what your bottle states and how you mix it. They are easily stored. The dosage is simple, produces a residual disinfectant, and it is safe to use. However, it can be corrosive, must be rinsed off, and it does not deactivate some of your organisms that you have. We know never to soak instruments in disinfectants prior to cleaning, because this can damage or corrode the instrument. The disinfectant might be inactivated by the blood and body fluids. Transportation of the contaminated items soaked in chemicals to the decon area may pose a risk to the healthcare worker and may contribute to development of antimicrobial resistance. Then the last area we're going to be looking at is sterilization. And there you see there's a couple of autoclaves and benchtop sterilizers that one might use. I'm not sure who has what, but just know that these are available. This is how you load an autoclave in a CSSD area. And please just remember, any of these processes that we've been speaking of, your cleaning, disinfection, and your sterilizing need to be validated. You need disinfection registers, monitoring and recording. It's essential. Processes have to be validated and documented. There must be a tracking and tracing system in place, and they need to be maintained regularly. We look at our staff protection, and please just also, as mentioned by the previous speaker, appropriate PPE must be worn. You want to avoid any production of aerosols, so give them the right gear to wear so that they don't, and teach them how to actually clean the instruments. They need to be immunized against hepatitis B, and they need to have training and proof of this training. And also, once again, role classification is mostly important. So in conclusion, we do see that cleaning is the first essential step in the decon process. It's important to ensure adequately decontaminated environmental surfaces and medical devices are done to prevent the transmission of pathogens and healthcare associated infections. Increase the frequency of cleaning during any outbreak situation, like what we've just had with COVID. And then your SARS-CoV-2, we do know, is easily destroyed, and no special processes are needed for environmental cleaning and decontamination of the medical devices. So my key message is first clean, then disinfect. You cannot clean without disinfecting and or sterilizing, but you cannot disinfect or sterilize without cleaning. I say thank you. Here are my references and then my acknowledgements to my diploma I did with Prof. Mehta, ICAN slides that I had been given, and to Tina Bradley, who has since passed away, who came and lectured us. She was an amazing lady. So thank you very much all.
Thank you very much, Michelle. I would like to just tell everybody we are going to have a 5-minute break now. While we are having the break, I'm going to play a video. So please don't leave. Post your questions in a question and answer box, and we will respond to that as soon as possible. It's just to give the interpreters a chance to just rest their voices. So just for 5 minutes, we're quickly going to have a break. Thank you. Sterilization routes. Okay, everybody, welcome after the break. I see some people have raised their hands. I just want to remind you that we cannot look after raised hands. Please post your questions in the Q&A box. And I want to now introduce our next speaker. And he is Dr. Damiolo Adiene, if I pronounce it correct. Sorry, I do apologize, Dr. Dami. He's a medical doctor and public health professional with at least 10 years experience working in the public, private, and non-profit health-based organizations. He is an infection prevention and control enthusiast, and his competencies include project management and research. He currently serves as a program coordinator for the Louth Environmental Cleaning Toolkit pilot project at the Center for Infection Control and Patient Safety. And he will take us through the experience that they've had now in Nigeria. Over to you, Dr. Dami. Thank you.
Thank you very much, Anna. Thanks for this opportunity. Good morning, good afternoon, and good evening, wherever you are across the globe. I also want to say thank you to Molly and Michelle for your excellent presentations. So I will be presenting on the implementation of environmental cleaning best practices at the Lagos University Teaching Hospital. Please confirm if you can hear me clearly and if you can see the screen.
We can hear you. If you can just put your screen in slide mode.
Yes, doing that now. Okay.
Yes, that's great. Thank you.
All right, excellent. Okay, so a bit, let me speak a bit about the Lagos University Teaching Hospital. It's a tertiary health center, health facility in Lagos, Nigeria. A 761-bed facility that serves a population catchment area of about 20 million people. I'm sure a lot of people know about the population of Lagos. We have inpatient admissions averaging about 25,000 annually, and outpatient visits over 400,000 per year or so. Louth has an isolation center for COVID, also has a functional IPC committee. And I think it's important to state here that prior to the implementation of best practices, which I'll speak about, we started sometime February this year. The hospital did not have a cleaning policy, that's environmental cleaning policy in place, as well as SOPs and structured training for the cleaning staff. All right, so like Molly mentioned, the implementation actually utilized the toolkit, which I would make reference to from time to time in the course of describing our experience in implementing best practices, using the 5 stages: we prepare for action, conducting a baseline assessment, and then we developed a prioritized action plan. We implemented the program improvements, and then currently evaluation and measures to sustain the impact currently ongoing. So these are the 5 phases of the project. I think one of our interpreters is currently unmuted. If you can please kindly mute. Thank you very much. So the implementation of best practices in Louth started, environmental clean best practices started February 2021, essentially by having meetings between stakeholders, the CDC, that's the US CDC, ICAN, and meetings also involving Louth, Lagos University Teaching Hospital. Like I mentioned earlier, the toolkit, which is the CDC ICAN Environmental Cleaning Program Implementation Toolkit, was utilized. We have the privilege of being the first institution where the toolkit was implemented essentially. So it's a pilot project. So what we did during the first preparatory part of the project was to get the necessary approvals from Louth management. And I would make reference to a lot of things in practice because I think that's the benefit of this aspect of the presentation. Some of the things we had to do, where we had to improvise, how we had to implement with our own context. Getting the approval of management from the beginning was instrumental to, I would say, so far the success of the implementation. So we did that within the month of March, and then we assembled a team. The team comprised representatives from the IPC team, IPC unit of the hospital. We had a representative from nursing. We had a representative from Louth administration, engineering. And subsequently, after we identified the priority ward, we also had representatives from the priority ward. I should also mention here that the best practice implementation started by focusing on the priority ward, for which we had to do a risk assessment, and I'll speak about that in a few seconds. We assembled the project team and had the first official meeting called the kickoff meeting on the 20th of March, where the project objectives, timelines were discussed, the roles of the different team members, explained. We had terms of references that were also discussed. Then, very importantly, we discussed the risk assessment tool, which we're going to use to identify the priority order. If you look on your screen, two things. There's a picture showing some of the project team members during the kickoff meeting that we had in March. And then to prepare for action basically is assembling the team, which we did, and then conducting a risk assessment, which I'll speak about shortly, and then identify the priority one. In conducting the risk assessment, we carried out a physical risk assessment across the entire hospital. This took about 3 days, going through every patient care area, from the wards to the outpatient department, across different faculties, departments, units. And we used criteria that consider the probability of contamination, vulnerability of the population to infection, and then potential for exposure. So what we did was the tool classified every patient care area into high risk, medium, and low risk. And so, for example, with the probability of contamination, we had 3 categories where some patient care areas were classified as high, some medium, and some low. And we assigned scores based on that. And then for vulnerability, we had patient care areas that had more susceptible populations, such as people that were immunosuppressed or neonatal populations. And so the scoring for those patient care areas were different from that for other patient care areas. And then potential for exposure basically focused on the presence of high touch surfaces as against low touch surfaces. And so using this risk assessment tool, the entire hospital was classified into high, medium, and low risk. And among the high risk areas, there were a total of about 19 of them. We had to come up with a criteria to further identify what our priority word would be. And so we used the criteria of the records of healthcare-associated infections, outbreaks based on previous surveillance. We also considered the high risk, patient care areas, such as neonatal population. And so amongst the 19 patient care areas that were identified as high risk, we narrowed down to 2 where there had been records of healthcare-associated outbreaks, healthcare-associated infection outbreaks, and also considering the neonatal population. So we ended the first part of our implementation by selecting the D1 word, which is neonatal outborn, and NNU, which is neonatal inborn. Please confirm if you can still hear me. Can you hear me?
Yes, we can still hear you.
Okay, great, excellent. All right, so then we did a baseline assessment. The baseline assessment, of course, having identified the priority awards, we conducted a baseline assessment, which was essentially a tabletop experience for the neonatal awards, which we had selected. This was done in the month of April, the second week of April. And so we used questionnaires, a structured questionnaire based on the toolkit. And just like Molly had mentioned earlier, we assessed the 5 different elements of environmental cleaning programs, including organizational elements, policy and procedure, staffing and training, monitoring and feedback, and infrastructure and supplies. So essentially, the way the questionnaires are structured are such that you have yes, no questions. For example, you could ask, you have a question like, is there a structured training program within the facility? And so you answer yes or no. And eventually the action plan, which is the next phase, now talks about how you come up with a plan in areas where there's a program deficit. So we conducted the baseline assessment within the priority awards by answering questions around the program elements, which I have just spoken about. Upon completion of the baseline assessment, we developed an action plan focusing on areas where we had answered no, areas where there were deficits. So for example, we focused on things that had to do with staffing and training policy. I mentioned earlier that the hospital doesn't have an environmental cleaning policy. So we had to focus on such areas. And there's something called a recommended action guide in the toolkit that helps to prioritize the actions, looking at the things that need to be in place before other things. We also had to consider the context of our hospital, of Lagos University Teaching Hospital. We had to think about plans that could be implemented within 3 months, considering we knew that we had just about 3 months to implement the improvements. And then the specific interventions were decided upon by the team. We considered the recommended action document as viewed in the toolkit, and we also looked at what was applicable within our context. And then we developed a detailed action plan document that included the actions to be taken, who does what, the target due date, the expected completion of the project, of the improvements. Then we moved on to the implementation of the program improvements, which was the more intensive part. Took about 3 months for us to accomplish this. We started from about mid-May, so May all through to July, the end of July, going into the first week of August. And so what we did, one of the prioritized improvements was the area of facility-based cleaning policy for the priority one. And so we developed a policy document for environmental cleaning within the neonatal wards. And the policy document included things like policy statement, definition of key terms, responsibility and reporting structure, staffing, approved cleaning products. The second major improvement we made was to come up with cleaning standard operating procedures for the priority wards as well, where we detailed things like cleaning schedules, routine cleaning, what should be done for scheduled cleaning, terminal cleaning, cleaning of body fluids and spills, cleaning of feeding related equipment and the likes. We also came up with an approved list of required basic cleaning supplies and equipment. We conducted an inventory of what was available so as to know, what the deficits were. And then we did a structured training. We developed the training curriculum, which I'll speak about briefly. A training curriculum was developed and a training plan was also developed. In doing this, we had to, once again, meet with the LUT administration, the chairman of the Medical Advisory Committee, the heads of LUT initiative and cleaning companies in Lagos University Teaching Hospital. Cleaning is done by some cleaning staff that are in the direct employ of the hospital, and then some cleaning staff that are employed by external contract cleaning companies. So we had to bring everyone together to discuss the modalities of the training, to get their buy-in, and we got good response from them. We also had to have a series of meetings after designing the curriculum with the facilitators and members of the IPC team. A major challenge, which I should also talk about here, is considering the population that we had to train, because they were predominantly cleaners. We had to consider the language challenge, and so we had to simplify the language used for training, and I'll talk about that shortly. So we came up with training guidelines, learning objectives for each module of the training. This is a list of the different aspects that cleaning staff were trained on: importance of environmental cleaning staff in IPC, personal hygiene and hand hygiene, the use of PPEs in environmental cleaning, and then cleaning techniques, which we broke into 2 parts. We also spoke about waste handling, monitoring and assessment of cleaning. And this is a picture of the facilitators at the training that was conducted. And then we had to do the training in 2 batches, considering the number of cleaners and the facility we had available, and also considering the fact that some cleaners had to be, on duty while cleaning, while the others, were being trained. So we conducted the training in 2 batches. A total of about 100 cleaning staff were trained, which includes supervisory nurses, the supervisors also from the external cleaning companies, health assistants, cleaners who they are referred to as maids here in Lagos University Hospital, and the porters. One of the reasons why we trained across these different cadres is because we realized that the role of cleaning in practice is not limited to just the cleaners or the maids within the hospital. And so we had to train the porters who were involved in some form of cleaning, the health assistants who usually clean the surfaces. Usually the maids here clean the floors. Health assistants do more cleaning of surfaces and also assisting the nurses. Within the priority ward, the nurses are saddled the responsibility of supervising the cleaners, and so they also had to be a part of the training. And training methods used with PowerPoint slides. We used videos, and so we had to translate certain videos to the pidgin, pidgin English language for them to understand. We had a lot of demonstrations. For example, the picture shows a demonstration going on, cleaning of a baby cot and also the incubator by the side. We used a lot of posters, job aids, and also we used songs. Currently, the evaluation and sustainability plans are in place. Our next steps are to carry out advocacy so that the hospital management adopts the cleaning policy and the SOPs that have been drafted. And then monitoring and supervision of the cleaning best practices currently ongoing on the wards. Plans to do that are in place. Of course, sustainability of the improvements that have been made, which includes, ensuring that the policies are adhered to, SOPs are in place, are being followed, ensuring that the approved cleaning products are being used, ensuring that supplies are available as and when due, and ensuring that there is ongoing training for the staff. And then ultimately, we plan to extend this implementation of best practices to other LUT patient care areas. Let me touch briefly on some of the challenges that we're faced with. Time was a major challenge. So what we did was to distribute the responsibilities for some project team members, across the board. The actual time that the Toolkit requested for implementation wasn't feasible in some cases and some parts of the project. And so we had to make use of weekends for carrying out the project. So sometimes we had retreats over the weekends to do what needed to be done, especially in terms of drafting the policy and procedures. Another challenge was the language barrier, which I already spoke about. And so we used pidgin English videos and sometimes the local language in training the cleaning staff. Thank you for listening. Please feel free to share your questions. God bless you all.
Thank you very much, Dr. Dami. That was great. I'm going to hand over to Dr. Wande Alimi from Africa CDC that will take us through the question and answers. Thank you, Dr. Wande.
Thank you very much, and good afternoon, good morning, colleagues, depending on where you're joining us from. Thank you to all the speakers for today. We have a few questions based on the time left. I know that Molly is already putting some answers on the Q&A. Please keep your questions coming. So the first question I think would be for you, Molly, is what can be a replacement for enzymatic detergent? This question has come in from Cameroon. So Molly, if you're happy to answer that.
Sure, yeah, I think I just answered a similar question on the Q&A. Because there was another question about standardized detergents. So we don't have as many standards for detergents as we do for disinfectants used in healthcare. Really, there are a number of different types of cleaning products that can be used that are just fine. So there are, we have detergents, we have powder soap, liquid soap, soap granules, really a number of variety of products can be used. They do not need to be enzymatic detergents. The most important thing for cleaning products is that, it's a neutral product. So should be somewhere pH 6 to 8, we say, and it should be easily soluble in both warm and cold water. So there are not a lot of specifications. Enzymatic detergent is okay, but it's okay if it's not. It can be another liquid soap or another type of detergent. The most important thing is for cleaning is really that it, you use water, make sure that it's soluble, and really that mechanical action. So that scrubbing to really remove all of the things that we can see and some of the things that we can't see prior to disinfecting. Hopefully that answers the question. I'll stop there.
Thank you very much. Michelle, the next question is for you. Is it necessary to disinfect an item that is going to be sterilized? This question was directed at you following your really nice presentation. Over to you, Michelle.
Okay, so it will depend on the type of item that is being cleaned and whether the manufacturer suggests a cold disinfectant or a heat disinfectant. If it's cold, then you wanting to use a liquid disinfectant, and then it cannot go and be put into an autoclave or a flash desktop sterilizer. Depending on, like I said, it all will depend on the manufacturer, but if it's been cleaned thoroughly, then the process to follow from that is then to be sterilized because you have now already cleaned it. So then the disinfection is part of whether it can go into an autoclave or not, depending on the type of item that you are speaking of. But if the person wants to direct it more to another explanation, then she can do that. Thank you.
Thank you very much, Michelle, for that. Dr. Dami, there is a question following your presentation. The question is, what is the nosocomial infection rate after the excellent intervention? So if you'd like to share a bit of your experience from the LUT's perspective, over to you.
Thank you for the question. The best practices implementation we just concluded our interventions in September, which was just last month. And like I said, some sustainability plans are still ongoing. The recommendation for evaluation, it has to compare what the healthcare-associated infection rates are before and comparing that with what we have after is about 3 months. So those rates will be obtained 3 months after the implementation. So we're talking about December, January, thereabout, because that's when we'll get an objective assessment of how effective the interventions have been. So I think that answers the question.
Thank you very much. Professor Shade, I will come back to you for the answer to this question. And just because this is something we continuously try to discourage, and I'm hoping that you would also bring at least some light to this. So this question is around using disinfectants sprayed on cars or on the food. As we have always known, maybe just to expand it further, Professor Shade, if you can talk a bit around disinfection tunnels, spraying on clothes, on bags, and when people go into large buildings or into offices and office spaces. Over to you, Prof.
Thank you very much. This is a topic that we keep coming to, and I think it goes back to what exactly we're trying to achieve. Because in IPC, we're trying to break transmission. So the question is, how is the organism being transmitted? One, and then in disinfection and cleaning and disinfection, we just talked about it. You need to clean because organic matter deactivates disinfectant, and the surface that you're cleaning is important. So let me take it one by one, especially because this has really come up during COVID. COVID is a respiratory virus. So it's in your respiratory tract and you breathe it out. Now, when people go through disinfection tunnels, what it does is it just pours disinfectant on the person. It has no value on the person passing through with the virus within him. So he's just going to walk through. And once he opens his mouth, the virus is out again. So it achieves nothing except that it looks really good. And, as I say, it has good photo opportunity that makes it look as though something is happening. But it has no value at all in breaking the chain of transmission because it doesn't touch the respiratory tract. It doesn't touch the virus within the respiratory tract or coming out, because as soon as you pass through, even while you're in there, you're talking, nothing is going to happen. And usually just pass through. In seconds, you're out. So it has no value. That's two. People constantly spray surfaces. So you're going to the airport, they spray your bag, they spray they're spraying the floor. Now, these are all surfaces with lots of organic material. The bags, for example, are leather. they're not things you can clean. And we always say you clean before you disinfect. So even if they were going to do it, then they need to have cleaned it, then they need to disinfect it. But again, the surfaces are porous. So even if there were organisms in there, they're deeper within this porous, and that little spray is not going to get deep. They don't get it wet anyway. So it doesn't work. The other thing is when you spray in the soil, and what organisms are you chasing? How much time? And then again, contact time matters, and quantity. Most times they just do a little spray and then you pass through. It doesn't work. So on many fronts, one, you don't get the virus as it's coming out, that's for the tunnel. Two, you're working on surfaces that make it difficult for the disinfectants to reach all the surfaces. Three, the contact time and the quality and the quantity of the spray does not reach every place and you don't have adequate disinfection, and then you do not clean before you do this. So on many fronts, it doesn't work. And it has been a very difficult practice to stop. And I think a lot of that is because it does have political value. And it's also, I think for government, sometimes there are people who have been given this assignment, and it does make people feel relevant. But in terms of IPC and breaking transmission, it has no value. Thank you very much.
Thanks very much, Prof, for that. Yes, we did. Thanks very much for that feedback. I see a few questions around if this PowerPoint presentations will be available in French. Just for your awareness, tomorrow, we will run the French webinar where we'll have French speakers also discuss this topic. We usually have English with Arabic and Portuguese interpretations on Wednesdays, and on Thursdays we have the French webinars. So please feel free to connect to the French webinars tomorrow. I think I have just one more question before I hand over to Anna. This question is coming from our colleagues from Cameroon around the explanations on duration of exposure. Molly, I think that was from your presentation. Feel free to answer that. If not, Michelle, I reckon that must have come up from your presentation as well. Over to you, Molly and Michelle.
Hi, yeah, I'm not sure it was from my presentation. I tried to answer one of the questions with regard to contact time. But maybe I will pass to Michelle to see if from her. So for contact time, I did provide an answer, but perhaps it's not it might be for Michelle, sorry.
Okay, yes, look, it all depends on the solution. So one would have to look at the manufacturer's guideline on the product that you're using, because there are various different contact times. If you can remember from our presentation, alcohol has a 60-second contact time, whereas your glutaraldehyde might have, I think it was 15 to 30 minutes. Chlorine releasing agents, contact time 5 to 10 minutes. So it depends on the solution that you are using. It will be stipulated on the instructions as to how long, but you can't let something lie overnight because that defeats the whole purpose. But there needs to be contact time on disinfecting any surface. And we don't go and I want to say you will spray your solution onto a cloth and wipe down the area or the surface, and then you don't go and take another cloth and wipe it all off again. There needs to be that contact time, but it will be stipulated on the specific product that you are using. I think the one table that I referred to from the National Department of Health, which has come and been formulated via WHO and CDC. I think it also gives you specific contact times for the types of solutions that are used. So if I can refer you to that depending on what country you're in and what type of item you are trying to disinfect. Thank you.
Thank you, Michelle. Thank you to all of the speakers and panelists for today. We will keep providing as much technical support as possible. Please remember to join the Telegram community of practice, where we'll have the experts available to provide some sort of technical guidance depending on the request you have made. So over to you, Anna, to wrap up today's session.
Thank you, Dr. Wande, and thank you very much to all our speakers, Molly, Michelle, and Dr. Dami. Thank you for our panelists, and thank you for all the participants. And as Dr. Wande said, you know, today is the English one with Portuguese and Arabic interpretation. Tomorrow is the French version. And next week is week 5. So please join us again next week when we're going to talk a little bit about antimicrobial stewardship and the impact with COVID. And then in week 6, we're going to talk about ventilation and the layout of hospitals. And then after that, we will have a series 10 as well. So please join the community of practice on Telegram or on the WhatsApp groups or wherever you are, or send us emails. All these presentations will be made available on the Africa CDC and the ICAN website, and we will be able to assist you if there's anything else. Thank you very much, and have a good afternoon or a good morning or good evening. Thank you. Goodbye.